Thank you, Dr. Debraj and the team, for making me a part of this instruction course. I believe this has been running for quite many years, and it's a privilege to be a part of this. I'll be talking about how I am setting up my aesthetic practice and what you can learn from me. There are no relevant financial disclosures. So, as oculoplasty surgeons, why do we need to set up an aesthetic practice? The first slide is the reason number one. If you see where I practice and I Google here Botox near B, the number of places that pop up within a 5 mile square radius are immense. There are more than 30 such places. So, this is the first reason that this is a treatment which is being in demand. A lot of people are offering it. A lot of it is done in the periocular rejuvenation, which I feel is our domain, and we should be at least aware about it and be skilled enough to know how to do it. How much of it we want to practice is something which we can eventually develop in our practice. The second reason is, as oculoplasty doctors, we do come across people seeking aesthetic rejuvenation of the periocular region, out of which surgical, of course, is one of the go to skill set that we have all acquired. But the list of non surgical procedures is immense, and there are so many options available that we need to be aware about them. How many of these we want to introduce in our practice is something, because they can complement our surgical results. They can help build up a clientele for the surgery. If somebody comes who doesn't want any downtime but wants to start off with something, we should be aware about these procedures. We should know how to perform them and offer them in a safe environment. The third reason is that botulinum toxin as well as hyaluronic acid fillers have had a deep rooted ophthalmology connection. In fact, the first published use of the toxin was for strabismus in the rhesus monkeys in 1973. And if you also look at the hyaluronic acid filler, it's derived from our ophthalmic viscoelastic devices, which was initially manufactured by the Cornell group for intraocular use during cataract surgery, and then later acquired by, which is one of the most popular AbbVie Juvederm products that we have in the market. So, coming to reason number four, the common concerns will present to the ophthalmologist. They can be in the younger age after refractive surgery. Once the glasses are off, the periocular region comes into focus. At a later age, once cataract is done and the glasses are off, again, aging and sagging changes in this region will present to the ophthalmologist. And the patients may actually say that, doctor, now that my glasses are off and I see this bump beneath my eye or a dark circle or some kind of a tired looking eye, which was not there when I was using glasses before. So, is there something you can do about it? With the non surgical procedures, they are less invasive, there's less downtime, and they're more or less reversible, and they form a good repertoire of what all we can offer for the facial rejuvenation. So, this is the reason number four, and how many of us are actually offering these treatments in our ophthalmology practices? To start offering them, the most essential step that we have is training. If we look at the curriculum for the ophthalmology, the dermatology, the plastic surgery, and the maxillofacial surgery, besides ophthalmology, all three do have a component of aesthetic medicine. While ophthalmology is focused mostly on the functional oculoplastics during the MS, MD, and even during the fellowships, dermatology really covers the minimally invasive skin treatments and energy based devices. And the plastic surgery MCH has a very well defined curriculum which includes both non invasive and invasive surgical procedures for facial aesthetics. The other way of gaining this skill would be to attend procedures and the trainings offered by the product manufacturers. And when we had done a recent survey of the oculoplasty people who had attended these trainings, a vast majority had already, and some were planning to attend these trainings to enhance their skills. So these are easily available and they should be regularly attended by all of us who are looking to include aesthetics in our practice. The next step is a clinical setup. We can choose to do all these procedures in the existing ophthalmology OPD with the slit lamp chair. Just need to add a few equipment that is required, basically a trolley with all the products that we need and a crash cart. Those are two essential requirements. We are all familiar with doing some procedures on the slit lamp chair, so including these, the important part is to ensure that your sterilization is intact. The second option to have a more aesthetic feel to the aesthetic procedures would be having a dedicated aesthetic practice room. So in my clinic, most of my procedures I do it in the slit lamp chair itself in the same room. Uh, I also have a flat bed which is my dry eye and dry eye workup room, which also has some devices which have kept there. And when you want the patient to really recline flat, you can offer these treatments in such a setup as well. I do collaborate with a dermatologist, and these are some pictures from his basic procedure room setup. If we see there's a flat bed, we have some area designated with the equipment, we have some products, we have some things on display, and we do have a proper disposal technique. And the equipment that comes in is, of course, autoclaved and sterilized as per the requirement. And the storage unit is also there for all the products that we need to have. The new setup that I'm building, I similar setup. I'll be having a slit lamp room with some procedures being done here. I'll be having a procedure room which is currently bare, but we're still in the phase of setting it up. What I've added is an aesthetic waiting room area with the good view, good sunlight, and a good facade, which while my patients are waiting for the procedure, they'll be able to at least feel more comfortable and not have the feel that they're sitting in a hospital. The procedures that we can start performing in the initial phase itself, we're all familiar with the functional Botox. We can add aesthetic Botox to it. Hyaluronic acid fillers, fat grafting, energy based devices, depending on what all we have. If we have radio frequency with us, or the intense pulse light, or the lasers, we can start with these. PRP and mesotherapy are also easy to use. If you have a centrifuge where you're making autologous serum eye drops, you might as well make PRP and do the injectable therapy for rejuvenation also. Thread lifts and other devices like high intensity focus ultrasound, body sculpting, all these do require some amount of investment and can be added on subsequently. Some procedures which should be strictly done in the OT include the hair transplant, the fat grafting, and of course invasive surgery like blepharoplasty. Ideally, you should also prefer to do the thread lifts in the OT in the initial phases. But whether you're doing a procedure in the operation theatre or the OPD setup, a crash cart should always be ready for any injectable procedure. The next step is collaboration. It helps with cross referrals, people referring the patients to you, people who are doing other aesthetic procedures but don't want to touch the periocular region will be sending. It's good to have a dermatologist on board. I personally have an in house dermatologist. Good to collaborate with estheticians and nearby salons also, where you can put up your standees and advertisements. But this may be a little tricky and you need to navigate depending on what the socioeconomic status in your city of practice is. Once you've decided to have your aesthetic practice, besides your existing advertisement page for your ophthalmic clinic, you need to have a dedicated page where you don't show more of pathology, where you actually show more of the aesthetic treatment outcomes and be regularly updating them. You need to have certain advertisements, soft advertisements, magazines, interviews, and you need to keep on showing reels and keeping engaging the people, the audience. You can show a little bit of the procedure being done to show how how the patient is comfortable, but be careful about the patient privacy. The next step would be keeping updated with trends. So it's good to be aware about what all is there in the market, what new things are coming. Do attend standardized webinars. A hands-on training and in-depth literature review of new products should always be done, but there is no need to follow blindly. And you must be aware of patients with body dysmorphia and unrealistic expectations who come in bringing standardized images of models and say, "Hey, doctor, make me look like this. I really want to look like this." So those are certain things where you need to know where to be careful and where to say no. The rewards from these non-surgical procedures can be, of course, immediate client satisfaction, making a difference. The patient walked in with a concern which you treated and they walked out feeling much better about themselves. There are financial rewards as well. As a surgeon, we tend to feel that the blade versus the syringe debate, which is an internal dilemma. But I think once you get into the hang of it, you should just make them complementary to your surgeries and be able to excel at offering both kinds of procedures. With this, I'd like to thank my audience for the patient listening and thank you to the organizing chairperson for this instruction course for making me a part of it.